Additionally, some of your comments the last time that you cannot hear me well. The voice quality and volume is controlled at your end. Please make the necessary adjustments on your devices as the source of the issue is not on my end. All right, so let's go ahead and get started and welcome once again. I'm just going to launch a poll right now. Okay, for those of you who have been here many times, I welcome you once again. And for those of you who are joining me for the first time, I hope that you will be able to gather as much information as you can. So let's go ahead and get started. Okay. One more. All right, as you could see, once again, we have a wide distribution of where people are attending from. I do thank you, and let's go ahead and get started. All right, here's a patient that comes into the emergency room, and you are now going to be taking care of this patient. So tell me, what are your thoughts at this time? What is your diagnosis? Okay, so some of you are answering well. I encourage you to answer. Of course, if you don't know, just stand by. All right, here's what you thought about it. Most of you said that it was an anterior wall MI. Some of you said inferior wall MI. And the others, there are some distribution of septal, lateral, as well as right ventricular MI. Okay, so let's go ahead and discuss this bit. The rapid interpretation of an MI on an electrocardiogram is actually of paramount importance in the emergency department as well as in any setting in the hospital. In general, high-risk patients with chest pain, actually according to the ACS guidelines, should receive an ECG within 5 to 10 minutes of presentation. So whenever you have a patient with chest pain, it is an expectation that you perform an ECG within 5 to 10 minutes, because it is vital that we are able to diagnose the presence of a type of MI called ST elevation MI with an acronym called STEMI. So in this particular ECG, let's take a look at what the characteristics are. And so for those of you who haven't done the webinar on 12-lead ECG, I ask for your indulgence, and I will invite you once that particular webinar will be presented. But at the moment, let's just go ahead and pretend that you are going to be analyzing a 12-lead ECG for the first time. When we're looking for a 12-lead ECG, particularly in the presence of acute coronary syndrome, what we're interested in is to look at the ST segment, because the ST segment tells us whether or not there's going to be a presence of a type of MI called STEMI or ST elevation MI. So we need to do it systematically. And if we take a look over here at lead 1, we notice that the ST segment is within the same plane as the baseline. So therefore, there's nothing abnormal in lead 1. However, when we go to lead 2, we notice that this is the baseline right here, and the ST segment is right over there. So there's a significant ST elevation. And that being the case, we're going to indicate that this is an elevation, because we're going to see further whether or not this ST elevation is also present in other leads. So let's go now to lead 3. If you take a look at lead 3, what do you notice? The ST is also elevated. Again, here's the baseline right here, and the ST is right over there. And therefore, this is a significant ST elevation. And thus, we are now going to indicate again that there's an ST elevation in lead 3. Now, in the diagnosis of MI, we don't look at AVR. So we're just going to ignore that for now, but we go to AVL. And if we're looking at AVL, the ST is depressed. So we'll just say that there's ST depression over here. We say that there's ST depression because the ST segment is way below the baseline. And moving to AVF, right over here, if we take a look at AVF, what do we notice? Again, there is ST segment elevation. So far we have ST segment elevations in leads 2, 3, and AVF. And in looking at or localizing MI in the heart, there are several things that we know. Each of these leads are going to be looking at a specific portion of the heart. As an example, leads 2, 3, and AVF are all looking at the inferior aspect of the heart. Let me just put that in a clear form right over here, okay? So 2, leads 3, and AVF are all looking at the inferior aspect of the heart. The inferior aspect of the heart is also known as the diaphragmatic portion of the heart. And this is usually a portion of the ventricle that is supplied by the right coronary artery. All right. And then we have other regions of the heart. And V1, for example, and V2 looks at the septum of the heart. So we call this the septal area of the heart. V3 and V4 is called the anterior portion of the heart. And leads 1, AVL, V5, and V6 are known as the lateral portion of the heart. Okay? So Again, leads 2, 3, and AVF looks at the inferior aspect of the heart. This is usually supplied by the right coronary artery. The septal, V1 and V2, this is usually supplied by the left coronary artery. V3 and V4 is the anterior portion of the heart, usually supplied by the left coronary artery. And leads 1, AVL, V5, and V6 are the lateral portions of the heart, and these are usually supplied by the circumflex coronary artery. Okay? So in order to diagnose SMI or ST elevation MI, one must first be able to identify the ST segment on the ECG. The ST segment, this one right here, hold on, right over on this area, it's right here, are going to be the interval between the ventricular repolarization and depolarization. And classically, whenever we have an ST elevation of more than 1 millimeter in the limb leads, meaning to say lead 1, 2, and 3, AVL and AVF, we call this an ST elevation MI. And if there is an ST elevation of more than 2 millimeters in the V leads, then we call this also diagnostic of an ST elevation MI. All right. So basically, when we're looking at a 12-lead ECG, any ST elevation is going to be a manifestation of ST elevation MI. A ST depression is a manifestation of ischemia. Okay, so are there any questions relative to this 12-lead ECG before we proceed? No questions? All right. So in addition, there was a question there whether or not there was an involvement of the other leads. And so let's go further. If we take a look at V1, we're just going to zoom this. If we take a look at V1, the ST is not elevated. The same thing in V2, it's not elevated. V3, there's no ST elevation. V4, V5, and V6. So therefore, we don't see any MI or ST elevation MI in the anterior leads as well as the septal leads and the lateral leads. Now, there's one form of MI called right ventricular MI, and this is also a case wherein you're going to have the presence of an inferior wall MI, which we have over here. And we know that there's going to be right ventricular involvement if the ST elevation in lead 3 is greater than lead 2. For those of you who have had this class, you already know that there's a right ventricular MI. So I'm just going to dispense of that particular discussion. And so the correct answer then for what we have done, for what we have discussed earlier, is that there is an inferior wall MI as well as there's a right ventricular MI. Okay. All right. So let's move on to the next situation. So you're watching this patient and you are now taking care of them in the ICU. Several hours later, the cardiac monitor technician hands you this strip and says, I see this on the monitor. Should we be worried about it? So that being the case, I'm now going to ask you the same question. Should we be worried about it? What is your diagnosis? All right, please indicate your responses. There's only 9 of you who responded so far. I know there's more of you. There's 23 of us in this webinar. Okay, so let me just share with you what you responded. Okay. All right. So let's analyze. The rhythm is irregular. So basically then there is a problem over here of rhythm. And we looked at the rate. The rate is 1, 2, 3, 4, 5, 50. And so it's a slow rate. And when we look and examine at the P waves, there are P waves that do not have any QRS complexes. Such is the case right over here, right over here, and right over here, and right over here. So we said that anytime there is a P wave without a partner, meaning to say that it's not followed by a QRS complex, then this is an indication that there is an AV block. So in this particular situation, then we can say that there is an AV block. There are 4 types of AV block, however, and so let's try to analyze what kind of AV block is present. So we have what is known as a first-degree AV block. In a first-degree AV block, all the P waves are going to be followed by a QRS complex, but the only problem is that the PR interval is long. And when we say it's long, it's over 0.20 seconds. So that's the major problem with a first-degree AV block. In a second-degree AV block, there are 2 types, type 1 and type 2. We also refer to them as Mobitz 1 or Mobitz 2. Now, in type 1, what's going to happen is that there is a significant pattern of the PR interval behavior, and that is that there is a gradual prolongation of the PR interval until such time then that there's going to be a P wave that is not going to be conducted. And in a second-degree AV block type 2, also known as Mobitz 2, the PR intervals are fixed. And lastly, in a third-degree AV block, the PR intervals are all variable. And this is going to be a very serious situation because the heart rate is going to be significantly decreased. So let's take a look again at this one, at this particular rhythm, and let's play the monitor. You go at the monitor and you see this displayed on the monitor. Okay, so this is the written portion of that strip that you saw on the monitor. The correct answer here is that there is a gradual prolongation of the PR interval. So let's take a look at the PR intervals. So this is the PR interval right over here. Here's another PR interval. And as you could see, it gradually prolongs right over here and right over here. And therefore, this is an AV Wenke block or a second degree AV block. And this is usually a rhythm or arrhythmia that is caused by ischemia in the area of infarction. So the mechanism of this particular arrhythmia is that this is usually a result of a reversible conduction block at the level of the AV node. Now, studies have shown that the site of block is likely at the crest of the AV node, meaning to say, if this is the AV node right here, and this is the beginning of the bundle of His, and then the bundle branches, it is believed that in this type of block, there's going to be a blockage right over here where the atrium and the AV node meet. So this is going to be a less serious problem than if the AV block were lower. Okay, so this is the reason why whenever we see second degree AV block, type 1 or AV Wenke block, we think that this is a benign rhythm. So it's something that we're not going to be worried about. It is usually going to be reversible. And in contrast to that, with second degree AV block Mobitz type 2, the block is going to be right over here. It's going to be lower, and therefore, this is going to be much more serious. Okay? So that's the difference between a Mobitz type 1 and a Mobitz type 2. All right. Let's go now to another case. You walk into the room and see the rhythm in the monitor as displayed over here. So take a look at it. And now we're going to see what this is. Okay. Here is the monitor strip. All right. So what is your diagnosis? Could you please type in your diagnoses in the chat box? Put in the chat box what your diagnosis is. Okay, thank you. Most of you are saying that it is a ventricular fibrillation, or I should say that all of you indicated that this is a ventricular fibrillation. Yes, indeed, this is ventricular fibrillation. Ventricular fibrillation is represented in the ECG by an erratic, non-identifiable waveforms, and therefore this represents that the heart is quivering. And thus, it is a life-threatening situation. This particular arrhythmia is death-producing. Now, I needed to ask, this thing. Hold on one moment. Okay. So which of these two rhythms a coarse ventricular fibrillation or a fine ventricular fibrillation have a better prognosis. Better prognosis. Meaning to say that if you have a patient in cardiac arrest, would you rather see a fine ventricular fibrillation or a coarse ventricular fibrillation? Okay. Let's go ahead and end the poll. And this is how you all responded. Okay. And so let's see. Now, the answer to this is that you pray that what you are going to deal with is a coarse ventricular fibrillation. In ventricular fibrillation, remember now that there is no organized depolarization of the ventricles. The ventricular muscle merely quivers, and as a result, there is no effective myocardial contraction and therefore no pulse. The resulting rhythm is going to be chaotic with deflections that may vary in shape and amplitude. And whenever you have ventricular fibrillation waves that are 3 or more millimeter in height, like for example, over here, do we have more than 3 millimeters in height? This is what's called a coarse ventricular fibrillation. Now, fine ventricular fibrillation is more dangerous than coarse ventricular fibrillation because there's less contractility of the myocardium, which therefore results in a smaller amplitude. There's also another implication over here. Whenever you have coarse ventricular fibrillation, it is believed that there's still a coarse ventricular fibrillation because of the fact that there's still oxygen reserve in the myocardium. So usually, when you see a patient in cardiac arrest immediately, you will see coarse ventricular fibrillation. Fine ventricular fibrillation indicates or suggests that there's no more oxygen reserves in the myocardium, such as what happens when you have a patient who develops cardiac arrest and you notice it after a long time. So let's say the patient is now unconscious for at least 5 minutes, you're going to see fine ventricular fibrillation. But if you see a patient who arrested right away and connected them to the monitor, it's most likely that you are going to be seeing a coarse ventricular fibrillation. Okay, so whenever you have a patient with ventricular fibrillation, you hope that there's going to be a coarse ventricular fibrillation. Additionally, the treatment for coarse ventricular fibrillation and fine ventricular fibrillation is going to be different, or the approach, I should say. So let's take a look at the algorithm for the treatment of ventricular fibrillation. So I'm now going to zoom in into this side of the algorithm, wherein you are going to have a fast rhythm or ventricular fibrillation. So once you identify that a patient has ventricular fibrillation, you give oxygen, you attach them to the monitor or the defibrillator, and ask yourself, is the rhythm shockable? If it is, so it is ventricular fibrillation, then we would need to deliver an electrical shock. Now, after the shock, we need to do CPR. And of course, we need to perform that for 2 minutes. Also, in the interim, we're going to start our IV, either intraosseous or intravenous access line, so that we will have the opportunity to deliver or to administer medications. Having finished the CPR for 2 minutes, we now determine again whether or not the rhythm persists. And if the rhythm persists, we need to shock them. And again, perform CPR for 2 minutes at which time we are going to consider the administration of epinephrine. And epinephrine is usually given every 3 to 5 minutes. It is also the right time to consider advanced airway as well as capnography. And then again, we defibrillate the patient. And if the rhythm persists, then we now give amiodarone. So these are the actions that you would have to take in the event that there is ventricular fibrillation. So when we resuscitate somebody, it is at this juncture that I would like to talk a little bit about what happens if the patient responds, or if we now have a patient that returns back to a viable rhythm. So we are now going to an algorithm called the post-cardiac arrest care algorithm. So what are the important items that are included in the post-arrest algorithm? Well, it includes optimizing ventilation and oxygenation, which means to say that we have to target the saturation to be maintained at around 94%. During the post-cardiac arrest phase, inspired oxygen should be titrated to maintain either an O2 saturation of 94%. Actually, it's between 92 to 98%. The goal is to avoid hypoxia and hyperoxia. We don't want it too much. We don't want it not enough. This reduces the risk of oxygen toxicity because excessive ventilation could be just as bad as no ventilation at all, because of the fact that whenever we have excessive ventilation, we actually reduce cerebral blood flow. Okay? The other thing that we want to do is to make sure that we maintain the blood pressure or optimize the hemodynamics. So notice over here, it says to treat hypertension right there. Hypotension, which is a systolic blood pressure of less than 90 millimeters of mercury, should be treated, and the administration of fluids as well as vasoactive medications can be used to optimize the patient's hemodynamic status. So what is this optimal blood pressure? Well, we want to maintain the mean arterial pressure of 65 millimeters of mercury or more than that. It's the MAP, not the systolic blood pressure, okay? So the mean arterial pressure should be maintained above 65 millimeters of mercury. And then, of course, the other thing that we need to remember is that, we need to make sure that if the patient has a SEMI, that they go for reperfusion. Okay? And reperfusion could mean to say a percutaneous coronary intervention, or PCI, in order to make sure that the patient is going to have a decrease in the amount of tissue damage that's going to be as a result of the myocardial infarction. And lastly, we have the targeted temperature management. Okay, what's targeted temperature management, or TTM? TTM, which was previously called therapeutic hypothermia, is the only intervention that has been shown actually to improve neurological outcomes after cardiac arrest. Induced hypothermia should occur actually soon after return of spontaneous circulation. The decision point for the use of therapeutic hypothermia is whether or not the patient can follow commands or there's a lack of meaningful response to verbal commands. One of the most common methods used for inducing therapeutic hypothermia is a rapid infusion of ice cold, meaning to say 4 degrees centigrade isotonic non-glucose containing fluids at a volume of around 30 mL per kilogram. And the optimum temperature for therapeutic hypothermia is to maintain the temperature between 32 degrees centigrade to around 36 degrees centigrade. That's approximately 89.6 degrees Fahrenheit to 96.8 degrees Fahrenheit. So we always maintain a range for at least 24 hours. So those are the things that we're going to include in the management of the patient post-cardiac arrest. I want to focus now on the lower part of the algorithm right here. And what can you use in order to maintain their blood pressure? We could utilize normal saline or Ringer's lactate, 1 to 2 liters as needed and given as a bolus. We could also need to recognize that we are not going to use preso receptors until we have an adequate volume and have corrected hypovolemia. Okay, so we never start with epinephrine or dopamine or norepinephrine. We always start with fluid in order to support the blood pressure. So at this juncture, we have finished the discussion of cardiac arrest, the management thereof, as well as post-cardiac arrest algorithm. So I want to pause here now to see if you have any questions. Are there any questions? Hello, can you all hear me? All right, thank you, Eileen. Appreciate it. Okay, let's move on to the next, and then we're going to have a break, okay? So let's go to case number 8. So Jill Michaels is a 23-year-old female. She doesn't look 23 in this picture. Arrives in the emergency department complaining of chest pain and palpitations. All right. She arrives in the emergency department complaining of chest pain and palpitations on and off for the past few hours. The history includes denial of any medical problems. The blood pressure is 190 over 110 with a heart rate of 126, respirations of 22, and a temperature of 99.8. Okay, so that's the medical history. And now the ECG monitor shows this. So what is your diagnosis? Okay, and the rest of you? All right, so some are answering on the chat. Okay, so let's take a look at the poll. This is how you all responded. 46% said atrial flutter, and some of you, 15% said sinus tachycardia, SVT, and ventricular tachycardia. So let's discuss. One moment. Okay, if we take a look at the rhythm appears to be regular. And the rate, we have a rate of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So we have a heart rate of 110. So we could actually, therefore, eliminate that this is an SVT, because SVT begins with a heart rate of 160. Okay, so let's think about that this is a tachycardia of some sort. And if it is a sinus tachycardia, each P wave should have a QRS complex. So this is a P wave with a QRS complex. This right here is a T wave. So for those of you who thought that this was atrial flutter, it indeed looks like atrial flutter, but we all have to consider that each one of these waveforms represents a P wave, a QRS, and a T. And in atrial flutter, we all know that the mechanism is that the atria is rapidly contracting at a repetitive manner, and therefore will be manifested in the electrocardiogram with multiple flutter waves. But this one is not multiple flutter waves or P waves, but rather we only have one P wave. Thus, the correct answer is sinus tachycardia. So let's take a look at the monitor, and this is how the monitor is displayed. All right, so while you're speaking to the patient, something happens, and this is what happens. So now we're going to find out what this is. Okay, thank you for participating. So let's take a look at how or share how you all responded. Majority of you said monomorphic ventricular tachycardia, and some of you chose the other options. Okay, so let's analyze. Before we analyze, let's take a look at what is demonstrated in the cardiac monitor. Okay, so in this particular rhythm, we have a regular rhythm. It is fast. The rate is over 100, and the QRS complexes are wide. Because the QRS complexes are wide, then we know that this is going to be coming from the ventricles. So we know that this is a ventricular tachycardia. Again, why did we think that it is ventricular? Number one, the QRS complexes are wide. And we call it ventricular for that particular reason. We call it tachycardia because the rate is over 100. So we have a ventricular tachycardia, and we all know that ventricular tachycardia are of two kinds. One, a uniform type of ventricular tachycardia, as illustrated here, and this is what's known as a monomorphic ventricular tachycardia. Mono means one, morphic means shape. So therefore, in this particular situation, we have what is known as a monomorphic ventricular tachycardia. There's another form of ventricular tachycardia wherein the form or the morphology of the QRS complexes are different. And that's, we call it a polymorphic ventricular tachycardia, but referred oftentimes by its French terminology, and that is what's called torsades de pointe. This is not torsades de pointe because all the QRS complexes are uniform. As you can see, the shape and its direction are all the same. They're all going downwards right here. So this is a monomorphic ventricular tachycardia. So what are the interventions for ventricular tachycardia? So obviously what we're going to have to do is to make sure that we're going to assess the patient, right? And so we're going to assess the patient, and we find that her blood pressure is 160/90. She denies any chest pain or shortness of breath. Her skin is warm and dry, and her respiratory rate is 20. So this patient is demonstrating ventricular tachycardia, but she is asymptomatic. So if a patient is asymptomatic, would you do CPR? Obviously not. Would you electrocute her or apply electrical intervention? Obviously not, because the patient is stable, right? So based on these findings, what then is going to be or are going to be your options? Well, we're going to make sure that we watch her, we observe her. We could think at this time of the administration of maybe anti-arrhythmic agents. Okay, because she is asymptomatic, correct? All right. So when they are asymptomatic, we're going to always think of assessing them for the signs and symptoms of physiologic deterioration. And that is remembering the acronym CASH. Does anybody remember what CASH stands for when trying to evaluate patients with arrhythmias? Anybody? Okay. We know that a patient is symptomatic when they display CASH, and it stands for chest pain. So if a patient is having an arrhythmia associated with chest pain, we call that symptomatic. If they have altered mental status, then they are symptomatic as well. And if they have shortness of breath, they are symptomatic. And the last one is hypo or hypertension. So this defines who is symptomatic. Okay, so whenever you are dealing with an advanced cardiac life support situation, symptomatic refers to the presence of these particular symptoms. Okay, so a few minutes later, though, Jill now appears to have become unresponsive. So if Jill is now as unresponsive, you're now going to have to assess her. And in fact, you do, and you find that she's not breathing and she is not pulseless. She is pulseless. So what is your action now? What is your action if she becomes unconscious? Yes, we now begin CPR. And what meds might be given in this scenario? Epinephrine, very good. So epinephrine is going to be a part of, or adrenaline is going to be a part of your algorithm for the management of a patient with ventricular tachycardia. So in summary, if a patient has ventricular tachycardia and they have a pulse and they are stable, you can begin with pharmacologic support, and that pharmacologic support might be in the form of amiodarone, 150 milligrams over 10 minutes. However, if the patient is having ventricular tachycardia with CASH or being unstable, then we might consider emergency cardioversion. And we usually start this cardioversion with the application of 100 joules and then incrementally go up. And lastly, if the patient does not have a pulse, then we would have to defibrillate. And in addition to the defibrillation is the administration of amiodarone during this particular resuscitation. Okay? Are there any questions as far as ventricular tachycardia is concerned? So let's review the algorithm for anybody with a tachycardia with a pulse. We know that if there is a pulse, then we're going to treat the underlying cause. If the arrhythmia now causes CASH, we're now going to consider synchronized cardioversion. And of course, we're going to make sure that we're going to determine if the patient is having ventricular tachycardia. So if it is a wide QRS complex, then we're going to have to consider the following right here. Okay? So these are the various forms of interventions that we're going to institute once we have a ventricular tachycardia. All right, for anti-arrhythmic interventions for these patients, we can use procainamide as well as amiodarone, as well as sotalol as alternatives for the elimination of the arrhythmia. And the last thing that we are going to talk about is the concept of cardioversion. When we cardiovert, we are trying to deliver an electrical current or synchronize it to a particular area. And so I'm just going to review with you the phases of an electrocardiogram. So we all know that the T wave is representative of ventricular repolarization. And during this time is actually where the ventricles are going to be very, what do you call that? Have a potential of responding erratically. So when we deliver an electrical current to a patient with ventricular fibrillation, what we're trying to avoid is actually the first 2/3 of the T wave. This particular area of the T wave is what is known as the vulnerable period, meaning to say that any electrical current that comes right over in this area could cause cardiac arrest. So whenever you are cardioverting somebody, you want to avoid this particular area. And thus, in synchronized cardioversion, the electrical current is going to be delivered right at the downstroke of the R wave. Okay? So you're synchronizing it to the R wave so that the electrical current will be delivered right over here. So if you have a patient with this particular form of tachycardia, then what's going to happen is that the electrical current is going to detect these points right over here and deliver the electricity right over here. This is what's called synchronized cardioversion. In defibrillation, the electrical current can occur anywhere, but in synchronized cardioversion, you're synchronizing it to these R waves so that it will deliver the electrical current at the downstroke of the R wave. That is the reason why when you cardiovert somebody, these points right over here are going to light up to indicate that the machine is sensing the tip of the R waves. Okay? All right. So that ends our discussion for the first part. Let's go ahead and take a 5-minute break, and we're going to come back and discuss case number 10. 5 minutes. Let's have a 5-minute break. Okay, welcome back. And let's go ahead with case number 10. So you have a patient, Ann Carter, 75-year-old female with a history of CAD, hypertension, atrial fib, and mitral valve regurg. Her physician has recommended she has an MVR, or mitral valve replacement, but Ann refuses, stating her sister died while having the same surgery. So Ann was admitted to the telemetry today for increasing shortness of breath. And this is her admitting 12-lead ECG. So let's find out what this is all about. What is your diagnosis? All right, go ahead and answer. I'm trying to have at least 50% of you participate, so please make sure that you do. Great. So let's take a look at how you all responded. This is how you all responded, and we will discuss to see whether or not you are right. Okay? All right. So let's go ahead and discuss this particular 12-lead ECG. I'm going to zoom in now, And first of all, let's take a look at the rhythm or the arrhythmia that is present in this particular patient. We see that the rhythm is irregular, right? It is irregular, and it doesn't have any identifiable P waves. So this actually corresponds to 2 of the 3 criteria for the diagnosis of atrial fib. Atrial fib is manifested in the electrocardiogram by 1, an irregular rhythm, the most irregular rhythm there is in electrocardiography. So therefore, this fits the diagnosis of atrial fib. The second being non-identifiable P waves. So we cannot identify any P waves right in this strip at all. And third, a wavy baseline. And we can see that the baseline right over here is wavy. So there is atrial fib in this particular situation. So you got that correct. So the first thing is that there's atrial fibrillation. The second thing is that we also see that the QRS complexes are wide, and it looks like there's slurring of the QRS complex. This brings to mind the possibility that there might be a bundle branch block. Okay, so again, the reason why we suspect there's bundle branch block is that there's going to be notching of the R waves, which are actually a manifestation of a bundle branch block. But we all know that there are 2 kinds of bundle. One, the right bundle, and the other one is the left bundle. And thus, what do we have to do in order to designate or to identify which bundle is blocked? The lead that would provide us with the key is lead V1. Okay, so whenever you are going to suspect a bundle branch block, what you need to do is to make sure that you look at lead V1. I'm sorry. So why do we look at lead V1? I'm now going to have a blank screen again, because lead V1 is going to give you an indication of whether the bundle branch block is a right or a left. So we look at lead V1. If lead V1 is right bundle branch block, it is going to have a predominantly upright waveform. I should say like this, RS. Sorry about that. Okay. However, if it's a left bundle branch block, the waveform in lead V1 is going to be predominantly negative. So my question to you is, in looking at this electrocardiogram, if we take a look at lead V1, is lead V1 predominantly positive or is it predominantly negative? Hello? It's predominantly negative, isn't it? Okay. So what bundle branch is blocked? What bundle branch is blocked? It's the left bundle. All right. So whenever you have a bundle branch block, remember now that the QRS duration is greater than 0.12 seconds. So it's a wide QRS complex. There's going to be a dominant S wave in lead V1, and that is the reason why it's mostly negative. And therefore, this is going to help you identify the bundle that is going to be blocked. All right? So do we understand now how we came to the left bundle branch block? So we have atrial fibrillation and we have a left bundle branch block. Do you all understand how we got that, right? So we're now going to evaluate the patient for the presence of MI. Do we see ST elevations in this particular 12-lead ECG? Yes or no? Not clear? Okay. So, Francesca, whenever you have a wide QRS complex with a slurring of the R wave, so slurring would be something like this, or it could be a W. So some people say M or W, okay? We know now that there is a bundle branch block, okay? So once you see a wide QRS complex with slurring, then we have a bundle branch block. Now, the problem is that we have two bundles. One is right bundle, and the other one is left bundle. So in order to determine what bundle is going to be blocked, you have to go to what lead in order to identify which bundle? Everybody, what lead do you need to look at in order to identify what bundle is blocked? Lead V1. All right. So if lead V1 is going to have a more upright complex, then this is a right bundle branch block. But if the QRS is predominantly going to be a negative complex, then we have a left bundle branch block. Okay, is that clearer to you now? Francisca? Is it clear to you now? Okay, great. All right, good. Yeah, I'd like for you to ask those questions or to ask me to return, because that's the only way that we're going to learn. Okay, great. So my question now is, do we have ST elevations in this ECG? And if we have ST elevations, where are they located? All right. So tell me which leads are going to be elevated. Which leads are elevated? Okay, lead 2. All right, very good. So lead 1 is there's ST depression. So lead 2 is ST elevation. Lead 3 is ST elevation. AVL is depression. And AVF is elevation. V1 all the way to V4 is normal, and V5 is slightly elevated, but V6 is not. So we have ST elevation in 2, 3, and AVF. These are all manifestations of what type of MI? What type of MI? If it's going to be 2, 3, and AVF, inferior wall MI. And is the ST elevation in lead 2 greater than the ST elevation in lead 3? Which one is more elevated, lead 3 or lead 2? Lead 3. So this therefore indicates that we have a right ventricular infarction. Okay, so here is how you responded, and the correct answer is, of course, that we have an inferior MI. 69% of you got that. And we have atrial fibrillation. 31% of you got that. And we have left bundle branch block, which is 6% of you got that. We also have a right ventricular myocardial infarction, which 31% of you got that correctly. Okay? All right. So going back to the case now, here is the rhythm again, which shows atrial fibrillation. And what is the physiologic impact actually of atrial fibrillation? What is the physiologic impact of atrial fibrillation? The physiologic impact of atrial fibrillation is that you will have a decrease in cardiac output. Why is there a decrease in cardiac output in patients with atrial fibrillation? The answer to that is because we lose what is known as atrial kick. Okay, so what is atrial kick? I'm sure that you all have heard what atrial kick is. Now, if this were an illustration of the atrium and the ventricles, so this is the atrium and this is the ventricles, the way in which the hemodynamic properties of circulation is follows. Blood rushes into the right atrium, and when it does, what's going to happen is it's going to start leaking right away into the ventricles. A lot of people think that whenever the amount of blood that goes into the atrium goes into the atria, that it waits for a while and it contracts and it pushes the amount of blood in the atrium to the ventricles. That's not what happens. When the amount of blood that goes into the atria, called preload, starts going in, it starts leaking all the way to the ventricles. In fact, 60% of the volume of blood actually goes into the ventricles right away. Okay? Now, the rest, however, is going to be pushed to the ventricles when the atria contracts. When the atria contracts, it contributes 1/3 of this volume right here. Did I explain that clearly? So whenever you have a return of blood into the atrium, okay, immediately the blood goes into the ventricles. 2/3 of this is what is known as passive filling of the ventricles. Atrial contraction, however, will contribute, once the atria contracts, it contributes 1/3 of cardiac volume in the ventricles. So whenever you have loss of atrial contraction, you're actually losing 1/3 of the potential cardiac output that you have. And this is the reason why in patients with atrial fibrillation, it might result in congestion of the lungs. And therefore, it could manifest in shortness of breath. Okay? So atrial fibrillation has physiologic effects. It is not good. And in addition to this physiologic effects, actually what's going to happen is that there's going to be a risk of the development of blood clots. Why do blood clots occur whenever there is atrial fibrillation? Well, because of the fact that blood is going to be stagnant actually in the atria because there's no more atrial contraction. So we have two atrias. One is the right and one is the left. If we have a right thrombus formation or a blood clot that forms on the right, what is most likely going to happen as a result of it? We're going to have a pulmonary emboli, right? What happens when we have a blood clot on the left? Where is it going to go? Most likely. Hello? Put your answers on the chat. Okay, and the brain, okay, or systemic circulation, but most likely it's going to be in the brain. Good, okay. So patients with with atrial fibrillation are at risk for the development of cerebral emboli. In fact, 97% of embolic strokes are caused by atrial fibrillation. You heard that right. 97% of embolic strokes are going to be caused by atrial fibrillation. So my question is, why is it that the risk in atrial fibrillation is going to be more on an emboli coming from the left side of the atrium rather than the right? Does anybody have an answer to that? Hello? Why is the left side usually the one that is going to form the blood clots in atrial fibrillation? Anybody? Nobody? Okay. So the left atrium has what's called the left atrial appendage, which is not present in the right side of the atrium. Okay. So what is this appendage? So if I were to draw the atrium, the left atrium has this thing like this, all right? And this is what's known as the appendage. So when blood is inefficiently moving over here, or the contraction of the atria is not present, it's most likely then that blood clots can form right over here. And that is the reason why, therefore, that atrial fibrillation is most likely to cause cerebral emboli because of the presence of this left atrial appendage. Okay? So that is the situation. So whenever we have atrial fibrillation, obviously we're going to treat them pharmacologically. And the treatment for atrial fibrillation includes the BCDA drugs. B stands for beta blockers. An example of that would be low pressure, or anything that is going to be I just had a mental fog. Anyway, beta blockers. The other thing is C for calcium channel blockers. An example of that would be cardizem, 10 to 15 milligrams slowly by IV. Digoxin could also be given. And of course, A stands for amiodarone. Obviously, if the patient is unstable and the patient develops CASH as a result of atrial fibrillation, then cardioversion could also be undertaken as a therapeutic intervention. So that is the treatment for atrial fibrillation and the management of patients presenting with atrial fib. I want to stop here to see if you have any questions at this point. Any questions? None? No questions. Okay. So let's go ahead and play Kahoot. For those of you who are not familiar with Kahoot, this is just a quiz, which is going to be a contest actually of who is going to be the fastest in answering the question. So I'm going to ask you to use your phone, and you're going to go to a site called kahoot.it. I'm going to put it in the screen in order for you to be able to participate, okay? Okay, so you're going to go to kahoot.it and you're going to enter this number, all right? So kahoot.it. Or you could also use the QR code and you're going to be able to access the game. All right, if you don't have a phone that is able to access kahoot.it, you could remain online to see how the game is played. Any more joining? There's only 10 joining. Okay, for those of you who are unable to join, just watch so you know how it goes. So let's go ahead and get started. Okay, so MI or STEMI could be diagnosed in the ECG, manifested by any of the following, or all of the following, I should say. ST elevation in at least two related or contiguous leads. And then, of course, the ST elevation has to be significant. When we say ST elevation is significant, it has to be at least 1 millimeter if we're talking about leads 1, 2, 3, AVL, and AVF, or 2 millimeters if we're talking about the V leads, V1 up to V6. So the correct answer here is ST elevation in at least two contiguous leads, and the ones that with the fastest response, and they were correct, are Eileen, Keenus, EL, Derek, and George. Congratulations. Okay, let's go to the next one. Okay, all of the following are treatable symptoms of bradycardia except, okay, so we all remember CASH, which stands for chest pain, altered mental status, shortness of breath, hypo or hypertension as indications of symptomatic something, okay, or a symptomatic arrhythmia. So let's see who were the fastest. Eileen again, Keenus, EL, Derek, and Brian. Congratulations. Okay, so we have an AV block and the PR intervals are all the same. So if the PR intervals are all the same, it refers to or it points to a Mobitz type 2. Okay, so let's see who were the respondents who were the fastest. Eileen Kinos has a streak, Derek L, EL, and Brian. Congratulations. Okay, so we have here a wide QRS complex. It's a tachycardia or a fast rhythm. So we have ventricular tachycardia. And the question was, if the patient is conscious and asymptomatic, what would be the appropriate RX? We certainly are not going to deliver electrical currents to them, so we can eliminate cardioversion and defibrillation. And between adenosine and amiodarone is going to be effective as an antiarrhythmic agent. Adenosine would be much more effective for narrow complex tachycardia, such as SVT. So let's see, Eileen again, Derek, EL, Kinos, and Brian are all in the lead. Congratulations to all. Okay, so we have here a fast rhythm. It's more than 160, so we know that this is SVT. And SVT is going to be treated by non-invasive manners first. So that includes Valsalva maneuver. All the rest over here, like cardioversion, adenosine, and cardism, are interventions that might follow. But the first one should always be non-invasive, and that includes Valsalva maneuver. Eileen, Derek, Kinos, Fatima, and EL, congratulations. Okay, whenever we have PVCs, we're going to evaluate them on their proximity to the T wave. So over here, you see the PVCs occurring right on the T wave. Over here, the PVC is occurring after the T wave. This PVC is very dangerous. And therefore, whenever we see this type of PVC, which is called R on T PVCs, it is imperative that it should be treated. Okay, so these PVCs are benign and need no treatment is false, because again, there are PVCs right over here, which are occurring very close to the T wave. So let's see, Eileen again, Kinos, Fatima, Derek, and EL. Congratulations. So whenever we have bradycardia and it causes symptoms, in ACLS, we need to treat them with either atropine or dopamine or epinephrine. And of course, whenever we have to use dopamine, the appropriate dose would be 5 to 20 micrograms per kilogram per minute. Okay, if you're going to give dopamine at a range of less than 5 micrograms per kilogram, it's not going to have that alpha effect. So it is dose dependent whenever you use dopamine. So let's see, Eileen, Kinos, Derek, Fatima, and EL, and Kinos having a 3 in a row. Congratulations. Okay, it should always be given fast. Very good. Adenosine has a very, very short half-life, and that is the reason why we have to administer it in a particular manner. Congratulations, Eileen, Kinos, Derek, Fatima, and Brian. The first amiodarone dose for tachycardia is 150 if necessary, we go to 300 milligrams. And so Eileen, Kinos, Derek, Fatima, and Brian again. Congratulations. Okay, the correct answer is the maximum amount, and that would be 360 joules. For biphasic, it's around 200 joules. Let's see. All right. Congratulations to each one of you, and that ends the Kahoot portion of this particular presentation. So this is the conclusion of our webinar for today. I would like to thank you for your participation. And before you go, I just would like for you to complete a evaluation. And we're going to do that by, I'm putting in the screen, on the chat, the link to the evaluation for this particular presentation. Once again, it was my pleasure being with you this morning. I'm going to stay online for the next 30 minutes to accommodate and to answer any questions that you might have. I look forward to having you again next week in our next webinar. Have a great day, and I hope to see you next time. Please make sure that you complete the evaluation. Thank you so much. Bye-bye.